All right, welcome back everybody to another episode of Pathagonia. So I just finished up my GYN rotation in my second year of pathology residency at Brooke Army Medical Center, and I'm getting ready to start my first Dermpath rotation on Monday. So I'm excited for that. There's certainly a lot of room for learning. I haven't seen a lot of derm specimens because we do have so many dermatopathologists at my institution. On SurgePath, I don't get to see as much skin, but we do get to rotate through with derm, and I'm going to see a lot of derm specimens over the next month. So wanted to do this quick video on the introduction to inflammatory dermpath. So in preparation for this, or just for my own studies, I did watch Jared Gardner has an amazing video on YouTube and on Oakstone on inflammatory dermpath, which kind of helped me establish a framework to approach this topic. So really, when you think about inflammatory dermpath, you want to think of it in various patterns or groups. And the first pattern that you want to recognize is spongiotic dermatitis. And from other areas in the body, we're used to seeing this spongiosis, or this intraepidermal intercellular edema, these white spaces between the cells. So that's consistent with a spongiotic pattern. You can have presence of widened intercellular spaces between the keratinocytes with elongation of the intercellular bridges. May be associated with inflammation like you see here. With chronic disease, there can be progressive Psoriasiform hyperplasia, usually accompanied by diminishing spongiosis or lichenification. So within the spongiotic dermatitis category, there are several entities. The first we'll talk about is very common, and it's atopic dermatitis, also known as eczema. So the diagnosis is spongiotic dermatitis consistent with eczematous dermatitis. The atopic triad to be familiar with is atopic dermatitis, seasonal allergies, and asthma. Acutely, this may lead to edema and can form vesicles, and then chronically, if atopic dermatitis sticks around long enough, you can have lichenification. It can appear similar histologically. Contact dermatitis and nummular or id reactions can all kind of appear similar histologically. Next up, we've got stasis dermatitis. So this is going to begin on the medial aspect on the lower leg, but can become circumferential. Clinically, it mimics cellulitis, and microscopically, you're going to see spongiotic dermatitis, vascular proliferation, which you see here. If you look at the image, you see all these vessels, vascular proliferation. It's going to be dilated, thickened blood vessels in the papillary dermis. You can see hemosiderin, as you see here, and chronic inflammation. All right, next up, classic. This brings me back to step one studying pityriasis rosea. So at first, with pityriasis rosea, you're going to have this herald patch, which is this patch here on the lower back you see on the right. And that's going to be followed by secondary lesions 1 to 2 weeks later after that original first herald patch. Typically, it's self-resolving in about a month, and it has what is called a Christmas tree pattern, where you can see these kind of like striations going down this individual's back. Clinically, the differential diagnosis is secondary syphilis, cutaneous T-cell lymphoma, and then microscopically, you're going to see a spongiotic dermatitis with mounds of parakeratosis, extravasated, I probably said that wrong, extravasated red blood cells, and then some exocytosis of lymphocytes. All right, we're into the next bucket or category, and this is lichenoid dermatitis or interface dermatitis. So for lichenoid dermatitis, you're going to have this band-like infiltrate that hugs the dermo-epidermal junction. So right at this junction between we got the epidermis up here and the dermis down below, And right at that junction, you've got this band-like infiltrate, classic for lichenoid dermatitis. Interface dermatitis, you're going to have basal keratinocyte hydropic change with vacuolization and variable lymphocytic inflammation. And you can kind of see this vacuolar degeneration or vacuolar change here. Next up, a few classic entities. Lichen planus, common entity of unknown etiology. In lichen planus, you can remember the P's, so you got pruritic, purple, and papules. Microscopically, you have this compact hyperkeratosis, lack of parakeratosis, the lichenoid band-like inflammatory infiltrate. You can have savate bodies, wedge-shaped hypergranulosis, and sawtooth reedy ridges. So that sawtooth reedy ridge pattern with that lichenoid inflammation, and then if you have a history of pruritus, purple lesions, or papules, you're going to want to think about lichen planus. And if it's just a single lesion on the trunk, consider lichen planus-like keratosis, or LPLK. Next up, so this entity, while it is a derm specimen, it's also relevant to the GYN pathology world that I just left, and that's lichen sclerosus. So predilection for anogenital skin also commonly occurs in the vulva in females, or on the glans penis, so in the genital area, and it can be associated with ballantitis xerotica obliterans. Microscopically, you're going to see homogenization of the dermal collagen with a variable band of chronic inflammation below edema and homogenization, vacuolar change, and atrophic epidermis. So I was always taught the red, white, and blue, so that kind of corneal layer, you have this red, and this homogenized stuff is white, and blue, you have this chronic inflammation or lymphocytic infiltrate that can be consistent with the blue pattern. Next up, we have a fixed drug reaction. So if you take a drug, can lead to one or a few circumscribed erythematous to violaceous brown plaques occasionally. Lesions recur at the same site with re-challenge. So if they're given the drug again, these lesions are going to pop up at the same site. And microscopically, we're going to have that vacuolar change, which we see here, these little vacuoles. Lymphs along the dermoepidermal junction and in the dermis. Necrotic keratinocytes, usually eosinophils, some neutrophils, and then prominent pigmentary incontinence or pigment incontinence, which you can also see in lichen planus and other entities. Next up, we have erythema multiforme. This is an acute self-limited disease. It's reactive in nature, usually from HSV, mycoplasma, or drug. You're going to get these targetoid dusky lesions, which tend to be distributed symmetrically in acral locations. So you may get them on the palms. And it's on the spectrum with Stevens-Johnson syndrome and toxic epidermal necrolysis. Microscopically, you're going to have erythema multiforme. It's going to lead to an interface dermatitis with necrotic keratinocytes. SJS-TEN is going to lead to severe to full thickness epidermal necrosis with variable inflammation. And Dr. Gardner was talking about in his lecture on inflammatory dermpath how to differentiate an erythema multiforme and SJS or TEN, specifically in like a test question or something. So if they're just giving more focal areas and they're saying it's targetoid, it's probably erythema multiforme. And then if it's more diffuse or full thickness and involving much of the body, then potentially you'll think about Stevens-Johnson syndrome or toxic epidermal necrolysis. But obviously in real life, things are different than tests, as we all know. So good to be mindful of both on your differential. Next up, we've got graft versus host disease, GVHD. This is usually post-stem cell transplant, that's transplanted immunocompetent T cells attacking the new host. It involves the skin, the liver, GI tract, and can cause a rash, elevated LFTs, diarrhea, and vomiting. And this acute GVHD we have pictured here on the right. You can see that kind of vacuolar change. At least that's what stands out to me. So acutely, you're going to have an interface dermatitis with necrotic or dyskeratotic keratinocytes, in which you can appreciate here some dyskeratotic and necrotic keratinocytes. Satellite cell necrosis, which is associated with, has an association of lymphs to necrotic keratinocytes. And then chronically, for GVHD, you're going to see sclerosis of the dermis, compact hyperkeratosis, and a lichenoid reaction. All right. Next up, lupus erythematosus. So this is a chronic cutaneous lupus or discoid lupus erythematosus entity, and it's usually only limited to the skin. Microscopically, for lupus, you're going to see epidermal atrophy, basal vacuolization, and thickened basement membrane zone. Subacute cutaneous lupus may be associated with mild systemic disease, but must rule out lupus first. And then microscopically, for subacute, you're going to have a lot of the same things. Epidermal atrophy, basal vacuolar change, necrotic keratinocytes, patchy to moderate chronic inflammation, dermal mucin usually prominent. And then on immunofluorescence, you'll have IgM, IgG, and C3 with a granular basement membrane deposition. All right, moving right along. One we certainly want to be familiar with is the Psoriasiform dermatitis pattern. And you're going to have marked uniform elongation of the reedy ridges. You can see how they're all elongated. So obviously in the Psoriasiform dermatitis family or category, we have psoriasis. Very common, very classic, a must-know for aspiring pathologists such as myself. So for psoriasis, the clinical findings that we remember, you're going to have this erythematous plaque and silvery white scale as shown here. Commonly on the extensor surfaces, the scale is micaceous or oyster-like. Microscopically, in the Psoriasiform dermatitis family or with psoriasis, you're going to have that Psoriasiform hyperplasia, confluent parakeratosis, hypogranulosis, so that absence of the granular layer is a key thing, and then neutrophils in the stratum corneum or epidermis, and thinning of the suprapapillary plates, as well as dilated BV and dermal papilla. So some other psoriasiform disorders, you can have reactive arthritis, Reiter's disease, pityriasis rubra pilaris, lichen simplex chronicus or chronic sponge derm, psoriasiform drug eruptions, herald patch of pityriasis rosea, and secondary syphilis can sometimes have a psoriasiform pattern. All right, moving right along, granulomatous reaction. So in these, you're going to have a discrete collection of histiocytes with variable numbers of multinucleated cells and lymphocytes, characterized by arrangement of granulomas, presence or absence of necrosis, separation or necrobiosis, presence of foreign material or organisms, and you must evaluate any granulomatous process for infection with phyte or GMS. And then you can use polarized light examination for foreign material to see if that's what's causing the granuloma. And on the image here, we have, these are sarcoidal granulomas or that you would see in sarcoidosis. right, next up we have Granuloma annulare. This is a self-limited dermatosis of unknown etiology. Rashes are often annular or round, and then microscopically you're going to have areas of necrobiosis in superficial or mid-dermis with surrounding palisaded histiocytes and lymphocytes with a central mucin collection. So granuloma annulare, or as Dr. Gardner referred to it as the blue granuloma, versus the rheumatoid nodule, which is classically a red granuloma. Necrobiosis lipoidica is next up. So this is associated with diabetes, and it's often bilaterally located on the shins. Microscopically, you have a normal epidermis, unless it's ulcerated. Linear palisading of chronic inflammation with some aggregates resembling germinal centers, like you see here. So you have some aggregates of inflammation. And then you have a layer cake appearance, which you can kind of appreciate here. It looks like there's various layers throughout this entity. Plasma cells, and this may extend to the septae of the fat. Other granulomatous processes to be aware of, so you have granulomatous rosacea. You're going to have persistent erythema and telangiectasia, usually on the cheeks, chin, and nose. Perifollicular and perivascular granulomas with chronic inflammation. Tuberculosis, of course, can cause a caseating granuloma. Again, that's going to be positive for phyte and AFB. And another interesting thing that Dr. Gardner taught on his Oakstone and YouTube video is caseating necrosis is actually something that can really only be identified grossly. We can't really comment whether it's caseating or not under the microscope. And he learned that from a lung pathologist, so I'm not sure who, but I learned it from the lung pathologist that taught it to Dr. Gardner, that then taught it to me. So now I'm passing it on. Next up, we got sarcoidosis. And these are naked, non-caseating granulomas, like we have up here. And you can also have granulomatous process with a foreign body reaction. So you'll have foreign body giant cells and polarizable foreign material. So you would imagine that if the body has some foreign material in it, like a suture or something else that is foreign, it's going to react to that, right? The cells are going to, you'll have inflammation, and this is probably a granuloma forming, trying to remove whatever is in the body. And as previously mentioned, rheumatoid nodule. So this occurs in subcutaneous or deep, extensive necrobiosis with fibrin deposition centrally, and it's often multifocal. And again, the buzzword for rheumatoid nodule that Dr. Gardner talked about was a red granuloma. Vesiculobullous reaction. As the name would suggest, this is when you have vesicles or bullae at any level within the epidermis or dermo-epidermal junction. The specific diagnosis depends on anatomical level of the split, the underlying mechanism, and pattern of other inflammation. Pemphigus vulgaris. So pemphigus vulgaris is caused by an autoantibody to desmosomes with intraepidermal vesicle formation, as you see here, this vesicle within the epidermis, and then suprabasilar acantholysis or tombstoning. So you got the basal layer, and then above that suprabasilar, you have this separation, leaving these little, what could be called tombstones, tombstoning appearance. We also have bullous pemphigoid, which is caused from autoantibodies to the hemidesmosomes at the dermo-epidermal junction. Pemphigus vulgaris, autoantibody to desmosomes. Bullous pemphigoid, this is an autoantibody to the hemidesmosomes. And this is a subepidermal cleft with abundant eosinophils. And there's obviously more to look up about all of these entities, but specifically with pemphigus vulgaris and bullous pemphigoid, you can look up the immunofluorescence as well as what antibodies are involved, and then maybe what it would look like clinically, etc., just to get a better idea. But we're just kind of just doing an overview of various patterns and just kind of a basic intro, and then we can obviously dive in further with our own studies. So dermatitis herpetiformis, you're going to have a subepidermal split with numerous neutrophils in the dermal papillae and micro abscesses. You have a granular IgA staining on immunofluorescence, and it's highly associated with celiac disease. All right, getting towards the end. So we've got vasculopathic reaction. These are pathological changes in blood vessels, including vasculitis and vascular occlusive diseases. So on the left, we have leukocytoclastic vasculitis, which is a histologic reaction pattern due to immune complex deposition. Microscopically, you'll have fibrinoid necrosis of blood vessel walls, endothelial cell swelling, perivascular neutrophilic infiltrate in karyorrhexis, or nuclear dust, and red blood cell extravasation. I think I got it that time. All right, so thrombotic vasculopathy. This is a histologic reaction pattern denoting presence of non-inflammatory small vessel fibrin thrombi, and with many possible etiologies such as DIC, hypercoagulable state, etc. Moving right along. So panniculitis is inflammation of the fat, and you can have septal or lobular, and you can have septal with no vasculitis, which would lead you to erythema nodosum, and then a septal panniculitis with vasculitis is polyarteritis nodosa. And that kind of makes sense, right? Like nomenclature wise. So vasculitis, if it does have a vasculitis, polyarteritis sounds like it's involving an artery nodosa. And then lobular vasculitis, you have erythema induratum. And then there's some other entities that can be associated with lobular panniculitis with no vasculitis. And I'll just let you reference those. I'm not overly familiar with them. All right, erythema nodosum. So for erythema nodosum, you're going to have red tender nodules classically on the shins associated with fever, malaise, and arthralgias. And microscopically, you're going to see thickening of the fibrous septae, lymphohistiocytic infiltrate, and some spillover into adjacent fat lobules. You're not going to see vasculitis that we just talked about. And then you're going to have multinucleated giant cells and granulomas. All right, polyarteritis nodosa. It may be systemic or cutaneous only. And these are tender, painful nodules on the legs with livedo reticularis, as well as vasculitis of the small and medium-sized arteries with overlap with microscopic polyangiitis. They may have fever, malaise, arthralgias, and myalgias with peripheral nerve involvement. So some other common diagnoses to be mindful of is arthropod bite reaction. And arthropod bite reaction, you have various degrees of wedge-shaped perivascular lymphocytic infiltrate with eosinophils, as seen here. And spongiosis, ulceration, blister formation, dermal edema, necrosis, insect tissue fragments, and spiders can lead to more neutrophils. So different bugs, different bites, different reactions in the skin, but just as a general pattern, this wedge-shaped perivascular lymphocytic infiltrate is good to associate with arthropod bite reaction. Another good one to know is dermatophyte reaction, where you'll have superficial fungal infection secondary to the dermatophytes, which are the trichophyton, epidermophyton, and microsporum. So a helpful clue for this is neutrophils in the stratum corneum. You want to get the fungal stains, GMS, and PASD to highlight the hyphae. And then you can have the sandwich sign, which is parakeratosis or compact orthokeratosis underlying basket-woven stratum corneum with dermatophytes located in between. Next up, we've got morbilliform drug reaction. So the histologic findings are non-specific and clinical correlation is essential. Basically, it's also known as SPD with EOs. And you can have superficial, perivascular, and interstitial dermal infiltrate, as seen here. Most often, polymorphous infiltrate of lymphocytes, neutrophils, and eosinophils. And a subset have vacuolar interface change. So you can see there's a lot of crossover between a lot of these entities. That's why inflammatory dermpath is notoriously hard, which is why I would recommend also watching Dr. Gardner's video just to bolster our studies. And it's going to be a topic that, like many things in pathology, if you study it once, you're not going to probably know as well as you would like to. So it's just going to be one of the things I love about pathology is it's going to be a lifetime of developing that skill set, reviewing things, and basically learning new things every day, right? So for someone that loves to learn, like myself, it's a great field. So next up, we've got pernio, also known as chilblains, caused by exposure to cold, damp conditions. And then microscopically, you're going to have this superficial and deep perivascular infiltrate of lymphocytes with prominent perieccrine inflammatory infiltrates. And then lastly, we have chondrodermatitis nodularis helicus. It's kind of fun to say. And this is a lesion of the outer helix of the ear that is usually a result of trauma. Clinically can be concerning for malignancy. And microscopically, you just see ulceration, a central fibrin deposition, granulation tissue in the base, and then adjacent telangiectatic vessels and perikeratosis. And the cartilage is usually uninvolved. All right, we did it. So we made it through the inflammatory dermpath intro. Thanks again to Dr. Schauberg and Kurt's Notes for letting us turn your amazing notes into audio-visual format. And thank you all for listening, and I hope you have a great weekend and a great upcoming week.